right, welcome to the Rocky Mountain MS Center's webinar series. This series is designed to give people with MS information to empower them to make the best choices for their lifelong brain health. I would like to thank a pharmaceutical company who has provided support for this program. Thank you to Biogen, EMD Serono, Genentech, and Sanofi Genzyme. Today's presentation will focus on family planning while living with MS, including topics of conception, fertility, and fertility treatments, as well as managing MS disease-modifying therapies before, during, and after pregnancy. Our presenter is Dr. Anna Shah. Dr. Shah was born and raised in Chicago, Illinois. She attended the University of Missouri, Kansas City for both undergrad and medical school. She went on to complete her neurology residency at the University of Michigan, where she served as chief resident in her final year. She completed her fellowship in multiple sclerosis and neuroimmunology at the University of Colorado and decided to stay on in a clinical setting. She sees patients with MS and related disorders of the nervous system. This webinar features a lot of important information. If you missed something on a slide and want to hear it again, we are recording this webinar and it will be archived on our website at mscenter.org, so you can replay it at any time. All live viewers will get the recording automatically sent to them. You will also receive a link to our evaluation survey. Please take a few minutes to fill this out, as it helps us improve future programming. We'll reserve time at the end to answer questions from the audience. You can submit questions at any time by typing them into the Q&A box on your screen. We'll answer as many questions as time allows. Today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. And with that, I'll turn it over to Dr. Shah.
Thank you, Kelsey. Hi, everyone. Thanks for joining. My name's Anna Shah. If we haven't met before, I'm one of the neurologists here at the University of Colorado MS Center. So hopefully this presentation will hit on a lot of the key questions and points that people have brought up or that I've seen raised in clinical settings on my own. But please don't be shy to ask questions if there is something that comes up. We are an open forum. So with that, I'll go ahead and get started and share my PowerPoint. All right, so as Kelsey mentioned, this is family planning in MS. You guys can see my screen okay? I feel like I always have to ask.
Yep, it's good.
Okay, fabulous. So here's a brief outline of what we'll cover during our talk. I anticipate the talk will be somewhere between a half an hour to 40 minutes, and then perhaps we'll save the rest of the time for questions. So we'll go through briefly what is the immune system, how it works, and how does it change during pregnancy. This will be followed by what are things to think about when you're planning pregnancy, with some details about fertility planning. And then we'll transition similar to pregnancy, and then the postpartum period, including breastfeeding. So this slide, I think, is one of the most important slides to understand when we're talking about how do we think about MS and what do we know about MS. So this nice graphic that we're seeing on the right-hand side of the screen is this older study called Pregnancy in MS Study, or the PRIM study, that was conducted primarily during the late 90s, early 2000s. And what they're really illustrating here is what are our chances, or what happens to relapse rates before, during, and after pregnancy. So that gray rectangle you're seeing there in the middle represents the 3 trimesters of pregnancy. And then to the left of that is prepartum periods, and to the right of that is postpartum periods. On the y-axis, what we're seeing is relapses per woman per year. The caveat I'll give to this is generally clinical relapses. And this study has a few limitations, primarily in that it was done a while ago. I already stated that it was done in the late 90s, early 2000s. But the other limitation here is that most of these patients were not on any sort of DMT. So it's a nice way to really illustrate what happens in the pregnancy period if we did nothing, or kind of what the natural history of it is. You'll see before pregnancy, so in that prepartum period, the average amount of relapses a patient was having per year is somewhere around 0.7. And then you'll see the significant drop during pregnancy itself, particularly during the 3rd trimester of pregnancy, where it comes down to about 0.2 relapses per woman per year. And then it really shoots up the exact opposite direction after delivery, particularly in the first 3 months postpartum, where it goes actually up to 1.2. So if you do the math there, you're seeing about a 70% reduction, essentially, of relapse rates during that third trimester of pregnancy compared to baseline, and then about a 70% increase in relapse rates compared to prepartum baseline. And there's a few different reasons for this, and I'm going to take a pause right there, and I'm just going to show you a quick slide about the immune system. Now, it is much more complicated than this slide lets on, but I will point out just a couple of things here. If we look under that adaptive immunity arm there on the right, there are a few different changes that happen naturally during pregnancy. And this is in every patient, MS or not MS. At the bottom, kind of near the middle, we see these TH cells. Those are called T helper cells. And in general, we think about the TH1 cells being more pro-inflammatory and the TH2 cells being more anti-inflammatory. And one of the largest changes that happens during pregnancy itself is we go from having TH1 cells being predominant to having a lot of those types of cells switch to the TH2 cells, which are the anti-inflammatory state. And if you think about it from an evolutionary standpoint, it makes a lot of sense because in general, we have this concept of immunotolerance during pregnancy. And what that means is we don't want mom's immune system attacking the fetus. So it makes sense for mom's immune system to transition into a more immunotolerant state or a less inflammatory state. The other big change that happens during pregnancy is, of course, the changes in hormonal levels as they're secreted by the placenta. So as our placenta starts to develop and really fully matures, we really see a steep increase in both estrogen and progesterone levels during pregnancy, really peaking at the end of the third trimester and then dropping precipitously after delivery of the placenta. How this plays a role, particularly when we're thinking about MS disease activity, is there have been a few studies looking at the use of estrogen as it relates to some mouse models that we use called EAE, seeing how that affects inflammatory activity. And we see that estrogen and progesterone can be quite protective to the brain. I'll give you an interesting tidbit that's not directly related to this, but one of the things that we actually tried as a community was to see if we gave women estrogen supplementation, would that function essentially as a DMT, because we know, again, estrogen helps decrease inflammation. While we did not necessarily see that pan out, we do know that that is somewhat responsible for those low rates of relapses, particularly during the third trimester. The other thing that happens during pregnancy is we tend to have a relative B-cell suppression. So for any of you out there that are on any sort of anti-CD20 therapies, whether that's rituximab, ocrelizumab, or ofatumumab, we know that those medicines are suppressing the B cells, which is quite effective in MS. And naturally during pregnancy, our bodies actually do that too as part of that immunotolerance state. So now that we know all of the fun physiology that happens or the changes that happen during pregnancy, what are the things that are really important for patients to think about when we're thinking about planning for pregnancy? Ideally, and I have two asterisks by the word ideal, and I'll explain why in just a second, we would like disease activity to be stable for about 6 to 12 months. We know that one of the biggest predictors of relapses postpartum is really how stable a woman has been prepartum in terms of disease activity. So the more stability we can provide prepartum, the better it translates into postpartum outcomes. Now, as you all know, it would be nice if things worked ideally, but they don't always necessarily. And of course, with fertility, there is an actual clock sometimes on fertility and pregnancy planning. So for my patients that are older or have other things coming up that might infer reduced fertility, I say we try and hit this, but it is not the end of the world by any means if we cannot. It is really important that you are on effective, reliable contraception until the point of being ready to get pregnant. If any of you are my patients, you know I probably pester you about this every single time we see each other. And it's important to be on good, reliable contraception. And I've listed out a few different examples of what falls under reliable and what falls under unreliable. This becomes important because we know the latest data that we have about pregnancies in the US, about 49 to 51% of all pregnancies are unintended. So it's not an uncommon thing. And it's not that we can't do things safely, but we like to do a little bit more planning when we think about pregnancy planning in MS. It should really be shared decision-making with your primary neurologist in terms of what are you doing, what is the timing you're thinking about. Although it seems strange to think about pregnancy planning discussions with your neurologist instead of an OB or gyne, it is really important to key in your neurologist about what you're thinking about family expansion plans. The other thing that becomes critical during pregnancy planning is making sure we've also managed the other comorbidities. This can be things like high blood pressure, high cholesterol, diabetes, any sort of thyroid dysfunction. There was one small paper that illustrated that MS patients that have uncontrolled comorbidities prepartum tend to have higher risk of adverse outcomes in the postpartum period. So what should go on our checklist when we're thinking about pregnancy planning? It is important to see an OB before actually getting pregnant. And one of the reasons this is relevant is we think about all of the medications that we use for MS symptoms, whether it's nerve pain, whether it's fatigue, spasticity, bladder management. It's important to know in what context these medicines are safe or not safe when thinking about pregnancy. One of the most common questions I get asked is, what type of OB should I be seeing? So of course there's the regular OBs, and then there's MFM, which is maternal fetal medicine, which are intended for more high-risk pregnancies. To be totally honest, I feel comfortable with my patients seeing their routine OB and don't feel as though they need to see a high-risk MS doctor unless there are other comorbidities at play. Here I've listed a few of the supplements that are important to think about. So prenatals, and or a separate folic acid regimen. This is very similar, if not exactly the same, to patients without MS. The only thing that I add that's a little bit different than our patients without MS that are pregnancy planning is the addition of vitamin D. Most prenatal vitamins will have some vitamin D in them, but they tend to just have 400 international units a day. There was, again, one really small study from years ago that demonstrated that maternal vitamin D levels may have a role to play in babies' future risk of developing MS. So as long as we can do it safely, I think it certainly makes sense to do so. Smoking cessation, incredibly important in general from a pregnancy planning standpoint, very important from an MS standpoint. We know smoking increases the risk of several pregnancy outcomes, including preterm labor and things like that. But then if we think about it from an MS standpoint, depending on what we're doing with medications, we don't want to provide another means for an increase in disease activity. I also tend to get an MRI scan as a baseline scan before someone attempts conception, just so we kind of know where we started. So when we get MRI scans in the future, we kind of know exactly where we were before getting pregnant and going through the delivery. All in all, probably the single most common question I get asked is, what are the risks of passing MS on to my future children? And we have more data about this, but we're still collecting more. So over here on the left, I have an illustration that if you can't read all the letters, that's okay. It's just for the general sense. Where there was a big genome-wide association study done, which is what the GWAS stands for. And they were really looking at, in all of these patients, we looked at almost 47,000 MS patients, what genetic abnormalities did we see and how did that tie in with the immune system? And they actually ended up finding about 233 variants. And I'm assuming the more and more we do this, we'd find more and more. So all of that being said, if a parent has one of these genetic variants, what is the risk of their children or offspring developing MS? And the good news of it is this is not a traditional genetic hereditary disease that we think about. For example, there are some diseases where we say if mom or dad have this, then their child is at a 50% risk or a 25% risk. In fact, that risk is significantly lower. We estimate that the risk is somewhere between 2 to 5% if one parent has MS. And if both parents have MS, the best estimate we can get is about 20%. Now, I'll put that in the context of the studies that we have looking at identical twins in terms of thinking about MS. If one identical twin has MS, the risk of their twin also getting MS is really only at 25%, which kind of tells you a little bit about how much the genetics plays a role. Now, not all of these 233 variants are the same. We know there are some that are higher risk. For example, there is a particular gene called DLA HRV 1501 that confers about 10.5% risk in terms of thinking about MS. And so it's important to put that into context. One of the things that I think will be exciting and we'll continue to get more information as we go on is some research that we're doing here called the RISE study and the DREAMS study. Now, what these studies are doing concurrently is looking at individuals from the ages of 10 to 30 that have a first-degree relative with MS. And within that, they're getting blood work, some genetic testing, vitamin D levels, infection levels like Epstein-Barr virus, and some other markers that we think might have a role to play in increasing an individual's risk of developing MS. And all the individuals in this study also get a really quick MRI. They're nothing like what most of our patients get, which is usually a 30 to 45-minute MRI. It's pretty quick where we're just obtaining the key sequences to look for any white matter changes. But that'll be something to keep your eye on when we're thinking about further risk stratifying first-degree relatives of individuals with MS. How does MS affect pregnancy? So in most cases, MS should not affect the ability of an individual to carry their child. And there's no identified change in the risk of miscarriages or spontaneous abortions. There has been no identified risk of increased birth defects in patients with MS. And no real changes in a decision on how to deliver. What I mean by this is if I have a patient that really wants to deliver vaginally, they can. If I have a patient that really wants to deliver through a cesarean section, they absolutely can. If they need to get induced, that is certainly not something that's outside the realm of possibilities. The last point becomes relevant for most patients to know to empower themselves with, just because I feel like there's been a little bit of a misunderstanding about types of anesthesia our MS patients can have. There was an old study well over a decade ago that illustrated that there was concern from anesthesiologists about types of anesthesia MS patients could get and whether things like spinal anesthesia, which is needed to have a cesarean section, would induce more relapses in our MS patients. And that has since been debunked. So if our patients want epidurals, if they need spinal anesthesia, whatever it is, I would defer to the OBs on that, on whatever is safest for however the pregnancy and delivery is going, but MS doesn't play a role in limiting that. Now, there are probably two outcomes that I would say MS does affect pregnancy with. There has been identified a lower birth weight in women with MS compared to those without MS. Now, this is not a significant difference, as on the order of a few hundred grams, but that is notable to mention. And we also do notice that more of our MS patients have more frequent induction and operative interventions during delivery. Now, the caveat to that is that study was published back in 2005, where most of our patients were probably more severe, and we didn't have great DMTs at that point in time. I'm a little unclear if that's necessarily the case in today's day and age. Okay. Let's talk a little bit about fertility, and there's lots of numbers here on this screen. I'll highlight that first bullet point first, which identifies, and this was a pretty recent study just published 2 years ago, where a greater proportion of women with MS have been diagnosed with infertility compared to those without MS. And this is interesting because the age ranges where this is true is in that 18 to 34 group and then that 42 plus group. And so there was originally a thought of, well, gosh, are more people being diagnosed with infertility in MS compared to non-MS patients because they were on treatments that could have harmed their eggs, or because they had disability or systemic inflammation, and that hasn't really quite panned out. Now, if you look at the difference in percentages, 8.5% to 8.1%, it's not a super significant difference, but that difference is still there and statistically significant. In that second bullet point, there is a 5-fold increase in need for what we call ART, or assistive reproductive technologies in those with advanced disease. The thought here is perhaps in those that have more advanced disease, they've had more inflammatory cytokines that have somehow impacted ovarian reserve. However, that thought was refuted with that third study that I'm seeing there that was done back in 2015, where they used markers of something called AMH, or anti-Müllerian hormone. And they really saw that individuals, even before their diagnosis of MS, so even before something clinically significant that led to that diagnosis, they tended to have lower amounts of ovarian reserve compared to those without MS. So what is the conclusion, and what do we do with that information? In general, the American College of OB/GYN recommends that individuals be referred to fertility experts, or reproductive endocrinology and infertility specialists, or REI, after trying to conceive for about 12 months. I would say in our MS patients, I would really recommend that referral after good attempts at conception, after 6 months, because one of the keys is identification of this issue as soon as we can, so we're really limiting time off DMT. I'm wondering, well, we'll just keep rocking through all of this. If you have a question, please submit it in the Q&A because it's a lot of material. And then maybe we'll just do them as a bunch all at the end. So let's talk a little bit about pregnancy. We talked about pregnancy typically being a stabilizing period in MS, and anecdotally, most patients feel better during pregnancy than they did in the prepartum period. And part of that might be all of those immune changes we talked about. What happens if there is a relapse during pregnancy? So in general, I would not expect relapses during pregnancy, but of course, it is not impossible. MRI scans are okay if we need to get them. I typically say we get them without the contrast agent, which is gadolinium, because that has proven to be potentially detrimental to fetuses. But MRI scans by themselves, because they don't contain radiation, should be okay. In fact, I would probably encourage them if we're seeing something that's concerning for a relapse in terms of new symptoms, never had them before, because it would be important to make sure, one, that's truly what it is, and two, we're not missing something else. Steroids can certainly be used during pregnancy, although I do tend to avoid them in the first trimester if possible. Steroid use in the first trimester has been associated with cleft lip and palate. And we can also do intravenous immunoglobulin therapies or plasmapheresis if needed. And now, how about the use of MS medicines? And I'm sure that is probably one of the biggest questions that comes up. And I'll go through some algorithms and some information that we have about all of these. But really what I'm going to emphasize is probably what Kelsey said at the beginning of this talk, which is really, it's important to discuss these with your neurologist and use shared decision-making to fully go through your particular situation. So I will just actually go through and talk about injection, oral, and infusion therapies during pregnancy and the data we have about it. So for glatiramer acetate or Copaxone, there's a lot of safety data about using this up until conception and throughout pregnancy. So this is probably one of those that I would say that would be okay to use. Interferons, good reports, good safety data to use up until conception. And then ofatumumab, I know most people think about it under the same umbrella that we talk about infusion therapies, but since it is an injection therapy, I'll put it here. So ofatumumab is a little bit newer, so we don't necessarily have as much data with this one. However, I think there is a lot we can extrapolate based on the data we have about other medications in this class of CD20 therapies. This one, I think, could possibly be even taken up until the time of pregnancy identification, but I would not continue it during pregnancy. And I'll go through a little bit why we might be able to use it up until the time of conception. Thinking about oral therapies during pregnancy, teriflunomide. So this one has a big, what we call black box warning on it about fetotoxicity and not being compatible with pregnancy. This is one that I personally tend not to put individuals on if they are women of reproductive age, or even men that are attempting conception with their partners. And part of that is just, there's been animal evidence of fetotoxicity. So there's typically a washout protocol that is needed to eliminate teriflunomide if someone does find out they're pregnant on this medication. Now, despite the black box warning, there have been newer studies that have arisen primarily from Europe, I believe, that perhaps the black box warning is not as much of a black box as we think it is. However, I'd be surprised if the warning got taken away. The second group of oral therapies, the sphingosine 1-phosphate receptor modulators, those include fingolimod or gilenya, ozanimod or zeposia, ponesimod or ponvory, and siponimod or Mayzent. Those are very small molecules, so they pass easily through the developing placenta. So those are definitely ones that I would say a big X in terms of thinking about taking them during pregnancy. These are particularly ones that in my patients that are thinking about pregnancy planning, I usually like to switch to something else before actually actively trying to get pregnant. The main reason for that is there is this risk of rebound disease, and there have been several well-documented case reports of women that have become significantly disabled as a result of rebound disease from these medications. So those I would definitely avoid. Cladribine or Mayzent, cladribine or Mavenclad. So there's no human evidence of fetotoxicity in this, and the washout for this is about 4 to 6 months. In terms of thinking about when to attempt conception efforts. This is also one that is a smaller molecule, should not be taken during pregnancy. And similar things with the fumarates, which includes dimethyl fumarate or Tecfidera, diroximel fumarate or Vumerity, monomethyl fumarate or bifiratam. Those should also not be taken during pregnancy. So probably the easiest way to think about that is oral therapies shouldn't be taken during pregnancy. Let's get to the infusion therapies, which I think is where I saw most of the pre-submitted questions asking about. So alemtuzumab or Lemtrada should certainly not be taken during pregnancy. On its prescribing information, it has a 4-month washout listed. And then the next two groups, so natalizumab and then the CD20 infusions, are a little bit different. So if we look at prescribing information, those are probably a little bit different than what we do in actual clinical practice. So I'm going to take a sip of water. So natalizumab or Tysabri typically is an infusion therapy that's given every 4 to 6 weeks. The biggest issue with natalizumab or Tysabri during pregnancy is we know 3rd trimester use has been associated with hematologic abnormalities, primarily anemia, in infants after delivery. And there might be some data about how it could be safe during the first 2 trimesters. Now, if you guys remember when we went back to that graph, we saw that each subsequent trimester had a slightly lower chance of having relapses. What I would not do with this medication, or personally, the way I don't practice is if someone has an unintended pregnancy on natalizumab, I would not withdraw it during the first trimester, because then we're introducing the risk of rebound already with what we consider the most vulnerable period during pregnancy. There have been, again, really impressive case series about significant rebound disease associated with Tysabri during pregnancy and significant disability accumulation. So in general, for these patients, I tend to continue my Tysabri infusions at a 6-week interval and probably preferentially stop around the 3rd trimester, so around week 30 to 32. If it needs to be continued during pregnancy, that would be one instance where I would say we would check baby's blood counts after delivery. Now, ocrelizumab and rituximab, again, slightly differently practiced here at the university than probably what's listed on the prescribing information. Prescribing information for ocrelizumab, I believe, says 6-month washout before attempting conception. And for rituximab, I believe it's 12 months. In general, these are larger molecule drugs. And what happens with larger molecule drugs is, unlike the smaller molecule drugs that we were talking about with most of the orals, they cannot cross the placenta and get to the baby unless there is a receptor there to take them from mom's bloodstream to baby's blood. And so in general, most of those receptors don't really fully form until the placenta is fully formed. So that's somewhere between weeks 16 to 22, depending on what you look at. So in general, if we think about how quickly these medicines leave our body when we talk about half-lives, and how long it actually takes for these drugs to be at risk of passing to the baby, most of us, I think, feel pretty comfortable with a 1 to 2 month washout period, meaning waiting about 1 to 2 months after infusion to go ahead and start attempting conception. Now, of course, not everyone gets pregnant the first time they try. And so I think it's important that we also think about, although we talk about these washout periods, they're usually typically the start of conception periods. The main concern for using this during pregnancy itself, or dosing during pregnancy, is could it cause baby's B cells to drop, and baby's B cells would be lower when they're born, which can have a lot of implications. One of those implications could be, are they at higher risk of infections? And the second could also be, are their vaccine responses not as significant as we would like them to be? There have been several well-documented studies about decreased efficacy of vaccine responses on these types of medicines, and there's no reason to think babies wouldn't be the same. That being said, we do use these medicines during pregnancy for some of the other autoimmune conditions we care for that require use during pregnancy. So what are our potential treatment paradigms for these patients? One is, could you continue treatment during pregnancy? Absolutely. The second is, could you continue until someone gets pregnant and then stop? Absolutely. 3, could you do a washout period and then attempt conception? This one I would say would be okay for the fumarates, for cladribine, maybe for teriflunomide. I probably wouldn't do that for the S1Ps, but have I seen it done? Absolutely. And then the fourth one is just basing off the physiology of pregnancy, which we kind of talked about. Okay. So this is just going back to that same graph, just in case anyone needed a reminder. We're going to focus on this right side of the graph now, what happens after delivery. So the highest risk of postpartum relapses is really in that first 3 months after delivery. And what are things that we know increase this risk? One of them is, what medicines were you on before getting pregnant? What kind of relapses or disease activity did you have before getting pregnant and during pregnancy? We know that individuals with higher disability scores prepartum tend to have more relapses postpartum. And the breastfeeding issue we'll talk about in just a second. In general, I think it is a good idea, depending on what you're doing with treatment options in the postpartum period, to consider getting a postpartum MRI scan so we have a sense of what has changed. Other things to watch out for postpartum, we often talk about recrudescence or pseudo relapses. Now, this means worsening of prior neurologic symptoms, and these, of course, can happen outside of the context of pregnancy. So these are things triggered by lack of sleep, stress, anything that increases body temperature, whether that's external heat, like it being summer, you're in a hot tub in hot weather, or internal increase in heat, like with exercise. These do not signify new true relapses. So particularly when we're thinking about stress, not only the physiologic stress the body has gone through when it's having a baby, and the delivery of a baby, plus the lack of sleep and things like that, it is not uncommon for patients to have pseudo relapses or recrudescence during during the postpartum period, which of course does not help with the stress levels. The most important thing to remember about this is these are symptoms you've had before. You cannot have pseudo relapses if you've never had that symptom before. The main symptoms that I often try to highlight postpartum are really fatigue, again, thinking about those interruptions in sleep cycles, and then bladder, especially for our female patients that have had vaginal deliveries. We also do know there are higher rates of postpartum anxiety and depression in our MS patients compared to our non-MS patients. So those are things that you may want to pay extra close attention to, or have partners pay close attention to, because those are things that we want to make sure that are getting addressed and you're getting help for, rather than feeling like you're on your own island trying to deal with it. So here is my plug for breastfeeding. I will preface this by saying, either way, whichever decision a patient makes, whether to breastfeed or not breastfeed, I would not base your decision purely on how it has to do with your MS. And of course, there's women that would love to breastfeed and can't for physiologic reasons, and that's okay too. So I certainly want to make sure no one places extra stress on themselves, feeling as though they need to breastfeed or exclusively breastfeed from an MS standpoint, because I promise there's ways for us to deal with any sort of situation, okay? There have been a few studies showing that exclusive breastfeeding tends to play a better or more prominent role in decreasing the rate of postpartum relapses compared to non-exclusive breastfeeding. So I throw it out there as something we know, but again, I would not exclusively breastfeed just from an MS standpoint. We're going to talk a little bit about drug use during breastfeeding, and it's important to know a little bit about what happens to breast milk. So the initial stage of breast milk, and this usually is what people describe when they say their milk is coming in, that initial stage is called colostrum. So that is a heavy, proteinaceous fluid full of lots of good antibodies for the kiddo. Now that is a time period where I say, gosh, there's a lot of stuff going from mom's blood into that colostrum breast milk. That would not be a time period where I would want anyone to restart treatments. Colostrum is usually peaks around day 5. And so after colostrum, we have something called transitional breast milk, which from my understanding is really just that transition between colostrum and mature breast milk. And most women will have mature breast milk within 2 weeks. Most of the data that we're talking about coming up on the next few slides about use of treatments is referring to the use in mature breast milk. So again, we'll kind of go through it in a similar fashion that we did with the pregnancy. So thinking about glatiramer, it has gotten an okay to breastfeed on it from the FDA. The interferons, based on the data we have, which is quite a bit, there haven't been any adverse outcomes noted in breastfed infants. Ofatumumab, I might just wait and include with our other CD20 infusion therapies. Similar thing with pregnancy, in terms of not using any oral therapies during pregnancy. I would not use any oral therapies during breastfeeding. And again, it comes down to the size of the molecule. Because all of our oral agents are smaller molecules, they easily can pass into breast milk. And so I, quite frankly, avoid all oral therapies when we're thinking about breastfeeding, regardless of the stage of breast milk we're in. So that includes our S1Ps, teriflunomide, cladribine, and the fumarates. So now let's talk about these 2 categories. Once again, natalizumab may be safe, and I always say may be safe. So again, prescribing information for both of these classes will say do not breastfeed on these. But we know, again, larger molecular weights, so larger molecules are less likely to be able to pass into mature breast milk just because of the way that breast milk is formed. There have been a few studies looking at something we call RID, or relative infant doses. That's essentially just something that the FDA uses for all medications when we're referring to breastfed or breastfeeding or milk concentrations of drug. And what that's doing is really just looking at mom's level versus the milk level. And so really the FDA considers anything less than 10% to be acceptable So with natalizumab, the studies that have been done have been somewhere between 2 to 5% in terms of that RID number. Now with ocrelizumab and rituximab, there have been smaller amounts of data, a lot more with rituximab because there is more translation into rheumatology and oncology and things like that. So with rituximab, all of the RIDs that have been identified are less than 1%. With ocrelizumab, I think the most recent data I saw also continued to be less than 1%. I haven't seen anything particularly with ofatumumab or Kesimpta, but I would presume it's probably pretty similar. Go over here. So I think one of the questions that was submitted before this webinar is, well, how would you treat? What is the most ideal way to treat? And again, I'm going to direct you to your neurologist in terms of thinking about what is the most ideal way of treating each individual patient, because of course not everyone is the same in terms of what their family planning goal is, how long they've had MS, how aggressive their MS has been. In general, this tends to be our most common treatment paradigm. We typically use a B-cell depleting medication for treatment, and this tends to be the infusions more is what I'm talking about when I'm referring to these, thinking about their half-life being around 20 days and the B-cell depletion really lasting about 6 months. If we say we're waiting 2 to 3 months post-infusion, you're really saying I'm limiting the amount of drug that can be transferred from mom to fetus, which is very helpful. And we know the highest risk of disease activity, again, relative to the lower risk in general pregnancy period, is in that first trimester. So it's nice because it provides coverage during first trimester and really limits risk of harm to the infant. In the postpartum period, we think about resuming medication about 4 weeks postpartum. I told you mature breast milk is typically around 2 weeks. We give it a couple extra weeks to be extra safe. Again, thinking about that high molecular weight, there should be less molecules passing into breast milk. The key question that I think we're working on getting answered, but probably don't have yet, is does this affect B cells in the babies? I have about a dozen samples that we've looked at and haven't seen any impact on B cells. But I think the other question is there a change in vaccine responses, which my hypothesis is going to be likely not. But again, I think it's important to think about this. I am hopeful that as time goes on, more and more of our pharmaceutical companies will provide more data to let us do this in a data-driven way. And I think we're getting there with just how much information has come out in the last 2 years alone. So the most important message from this talk, and it looks like I talked for about 45 minutes straight, most important message from this talk is there's lots of ways for our patients to do whatever they want to do from a family planning standpoint, from an MS standpoint. I think it's just a little bit of extra planning, but nothing breaks my heart more than patients that I have that say, I can't do this because of my MS, because the good news is we can really, if there's something you really want to do from a family planning standpoint, I think we can make it happen, whether that's having 1 kid, having 10 kids, breastfeeding, not breastfeeding. And I will end with a picture of my 2 sweet little nuggets that I still force in matching clothes. And one of the reasons why I'm so passionate about this. So I think we'll take a break there and perhaps we'll do the questions. Kelsey, what do you think?
Excellent. Thank you. That's been fantastic. We did have a couple of questions submitted, so I'm going to go ahead and start off with those, but please, if anyone else has questions, feel free to submit them. We had a couple more questions about rituximab and pregnancy. So is there any risk to a fetus when mom has had rituximab in the body at all? And then if it doesn't cross into the placenta till the 2nd trimester, when is that ideal time to start trying to conceive?
Yeah, really good question. So I'll answer the first question first. In terms of the data that we have available, so if mom has any exposure to rituximab during pregnancy, and we've got data about this because I mean, not only do we use it in other autoimmune conditions, things like NMO is particularly what I'm thinking about that we use it in, but it's also used in rheumatology quite a bit. It's used a lot in oncology if it's needed to be used. One of the biggest things that we see is babies' B cells being lower when they're born. Now, it is not to say that every mom that has rituximab exposure during the second and third trimester will have an infant that has lower B cells. But it's certainly something we pay attention to, certainly something we screen for, just because of the implications that can happen if baby is born with lower B cells. In most cases, babies have really active bone marrows, and so it does not take them long to repopulate their B cells. But again, things that we want to be aware of. And I think your second question that you just asked, Kelsey, was what is the ideal timing?
Yes.
So I will do a hypothetical situation because I think it might help a little bit. If we think about how long it takes for rituximab or Ocrevus to leave the body, it's a little bit north of about 20 days. I think it's like 23. And so we talk about this concept of something called half-lives in terms of how long it takes for drug concentration in the bloodstream to get cut in half. So the first half-life is going from 100% of the drug to 50%, and then 50% to 25% is the second half-life, and so on and so forth. So pretty commonly when we're talking about medications, we think about it 5 half-lives to eliminate most of the drug. So if we say, gosh, we're saying like 20 days, and we do that by 5, we're at about 100 days. So just like about 3.5 months-ish. So theoretically, if someone got pregnant the day of their infusion, about the time it would take for it to get out of the body would be about 3.5 months. And that's around the time I'm saying these receptors develop, if not a little bit later. So usually around 4.5. So theoretically, there shouldn't be an issue with these medicines passing to baby, even if you got pregnant the day of. And now I think uniformly what neurologists are is we're not very adventurous when it comes to things like this. So interestingly, in the rheumatology literature, they have no issue waiting less than a month for women to get pregnant after rituximab, and they give 2 thumbs up for breastfeeding on rituximab. And so I think we tend to be more conservative as a field in general, which I think is actually to the detriment of a lot of our patients. But ideally, I mean, you could get pregnant the day of. We tell people to wait a couple months. In general, my treatment paradigm is usually try after an infusion, try for 6 months. If you haven't gotten pregnant, I send you to a reproductive endocrinologist, and then we do another infusion. But I know everyone's got little nuances that they may do differently. So talk to your neurologist about what their thoughts are too.
And you just answered this question for the anti-CD20s, but we had a question: what happens if I stop my DMT but accidentally get pregnant before the washout time?
It probably depends on the DMT. So there's so for example, if it was like teriflunomide, that one I'd be a lot more concerned about. We'd probably have to go through a proper elimination procedure with the cholestyramine. If it was something like a fumarate, I don't worry about those too much because their elimination is pretty darn quick. The S1Ps, I'm a little plus or minus. About the thing I worry about most with those is the risk of rebound disease. There has been, in terms of fetal abnormalities, there have been a variety of ones described without a very clear pattern, but some of the things we watch for, again, are babies, blood work, and then heart issues. Mavenclad, I worry a little less about if their lymphocyte counts or their blood work is normal-ish, depending on how soon it was after delivery of that. But I think, again, it depends on what the medicine is. And I hope I hit on all the ones that I talked about washed out with.
I think so. How much does breastfeeding decrease the risk of relapse in the acute postpartum period?
Really good question. So again, it depends. And now I'll say this with a huge caveat of the data that we have is on the premise of you either decide to breastfeed or you get your medicines. And so the difference, and it's a little bit controversial because it's not the same in every study. Some studies, it's less than 10%. Some studies, it's like 0.25% or 25%. But that being said, I think in the situation that we're using medicines or restarting medicines, as long as we're using the right ones that are safe, I mean, I think that risk is infinitely smaller by doing both together rather than one versus the other.
How do you feel about the appropriateness for some folks who are on cladribine to plan a pregnancy 6 months after their last dose, if they're clinically stable?
I think that's just fine.
And how significant is the anemia in infants born to a mom on Tysabri? Is it a recover quickly situation? Would it be reasonable to stay on Tysabri at 6-week intervals?
Yeah, that's a good question. You know, I don't know that I know the data in terms of how quickly the anemia resolves. I would imagine it would be pretty short-lived, within a few months at least. But I don't know that I know that data exactly off the top of my head. Usually most of those anemias are mild. There might have been some case reports about moderate, what we consider moderate anemia. As far as I know, there haven't been anything that's severe anemia or something like that requiring transfusions, as far as I know.
I know you touched on this one a little bit in your presentation, but I hear it come up a lot as well. Talking about how the lack of sleep that comes with having a newborn also contributes to both that recrudescent pseudoflare activity. Just kind of how would you approach talking with someone about that?
Yeah, it's a hard one. And obviously not everyone's resources are the same. My bias is if there's something we can outsource, it makes sense to outsource it. Meaning if you've got a partner, if you've got a willing grandma that just thinks her grandkid is the bee's knees and wants to watch them all night, I mean, take them up on it. Outside of that, it's really tricky because you can't control the sleep patterns, or if you're breastfeeding, the feeding patterns of your little angel. And so it can be really hard. So I think the biggest thing is to remember outsource or delegate where you can. So if you are waking up every 2 to 3 hours with your baby because you're breastfeeding and you're feeding at that interval, then maybe say, hey, someone else can take care of the dishes or things like that. There's obviously medicines we use for MS fatigue, some of which are safe during breastfeeding, that can be utilized, but it's kind of like putting a Band-Aid on it, and it's not really going to do too much because eventually it'll catch up with you. I think trying to do that, this is anecdotal experience from being a mom, but good sleep habits for your infant are going to be helpful too. So hopefully that period of time does not last quite as long.
And then also, if folks we have one woman approaching 39, just diagnosed last year. Is it risky to consider getting pregnant in the next couple of years? What would you, what advice for maybe slightly older patients?
Yeah, I wouldn't worry about it. I would say if you want to have a baby, we help you have a baby and we just do it in a safe way. But that might not be what everyone says.
Wonderful. That is all of our submitted questions so far. So I want to say thank you, Dr. Shah. Thank you, everyone, for your questions and for your participation today. We have recorded the webinar. We'll put it up on our website. And again, please make sure to check out our evaluation so that we can improve future programming. Thanks.
Thank you, everyone.